through the same thing because I think it is foundational and important. So, and I'm going to talk about ventilation or ventilator-induced lung injury, as it is now called, and patient self-inflicted lung injury, as it is also now becoming famous. No conflicts of interest. Let's go back. I like this paper all the time. Lancet, 1967, when Ashbag, Bigelow, Patty, and Levine, they coined this term, acute respiratory distress in adults. It was still not, it was the first time anybody defined a new syndrome. How often that happens in medicine. That was what the last decade was all about. What they basically did is defined or showed 12 patients with varied etiology. You can see here multiple trauma, lung contusions, shotguns, viral pneumonia, all of those, all of them came with an acute respiratory distress, which was acutely in onset. It was not chronic. They did not have it as background. They came with hypoxia, and a lot of them were fluid positive already, fluid overloaded. They had acidosis and they had hypotension. And they went on to describe that this is something unique. This is an acute lung injury, which mimics the neonatal respiratory distress syndrome. And so we call it as acute respiratory distress in adults. Many may not know that the paper was not always accepted in all the journals. And in fact, one of the reviewers thought that this was something called respirator lung. The term respirator lung was famous then, especially after the pandemic of the polio, where children or adults who had polio who went on to the positive pressure ventilator then died, found to have lungs that were terribly injured. There was no business why polio should have bad lungs. So they concluded that these lungs were badly hit because of the ventilator, because of the positive pressure. And they used to call it as respirator lung, which is to say Vili, nothing else. Which means that, even when the term ARDS was being coined, Vili was a contender. Vili was a contender to its differential diagnosis. Now we know that acute respiratory distress syndrome presents as acute respiratory illness. It has pulmonary inflammation and edema, which is biologically something like diffuse alveolar damage. So it comes as hypoxemia, and that is how we define it clinically. But biologically, it is alveolar damage. And the presence of that edema and inflammation is in the absence of left heart failure, which is very, very important, because is it heart or is it the lung? That was the basic question for centuries, and that kind of is almost sorted. It was a relatively recent paper in JAMA from the adult world, encompassing 50 countries after they redefined ARDS in 2012. The mortality in adult ARDS, even with the new definition, has been 30 to 50%, which is pretty high. And then in 2009, after redefining the pediatric ARDS, we had this party study which showed, depending on how we look at it, the pediatric mortality can be 15 to 30%, depending on where it is, et cetera, et cetera. This is pretty high mortality for an acute illness in both, whether it's pediatric or an adult. The real question is why? Why is ARDS such a easy way to die? This is a diagram that I showed you last time, I believe, from Irene Thelias's chapter. We know that ARDS is all this, right? We just discussed. But Vili, which is the way we treat ARDS, which is this part, is by offering a ventilator, where the ventilator takes care of the patient acutely, gives us survival, achieves gas exchange, offloads muscle work. It also adds to injury, which is volu, baro, atelecto, and biotrauma. We'll go through some of these terms today. Whatever it does, it produces a picture which is similar to this picture of ARDS. For instance, if I have to study ARDS in the laboratory in animals, all I need to do is give them Vili, bang their lungs with very high tidal pressures, or whatever form of injurious ventilation I would like to use, and it will produce inflamed, leaky, edematous lungs, which is basically ARDS, and then I can study whatever therapy I want to study. which is to say that your friend, the positive pressure ventilation, which is taking care of this sick lung, is also adding injury. And this is the problem. So ventilation in ARDS is one side, is like there are two sides of the same coin. One side of the coin is that there is life support from mechanical ventilation, without which the patient will certainly die. On the other hand, your friend, the ventilator, adds injury to the lung, and adding injury to the sicker organ will take the patient towards death. So it is where we give adequate life support, but we prevent lung injury, is the balance that we need to achieve with mechanical ventilator. And that's the entire purpose of why certain numbers have to be targeted, why you keep pressures below some limits or tidal volume, etc., etc. But this is the fundamental philosophy. Now, there are certain classic concepts of Vili, as we know, as distension trauma, which kind of goes together with, for the both terms of barotrauma and volutrauma. Then atelectasis, which is closed lung. And then there is biological trauma, which is inflammation in the lung and distant to distant organs. I will add some newer concepts, one of them, which I've been working on, and then this concept of Vili-Psili, which again, part of it has been done in our laboratory at SickKids. So, classic concepts. My purpose today will be to go through some very classic and old papers. If possible, read through these papers. It'll enlighten you. It'll bring up some different idea of where everything starts. You know, we get taught 6 versus 12 ml per kg. That's a comma after which we learn. But where did it all start? Why did we come to that place? And it has come through rigorous work, preclinical modeling, etc., etc. And it's just actually taken decades to reach to this point where we try to practice safer ventilation. Now, this is a paper that gets famously quoted in all the papers of Vili or ARDS at times. This was done in Boston back in 1970. This was a paper where a balloon model of an alveolus is being prepared. It's it was an elasticity model where you're trying to study stress distribution inside an alveolus. Basically, these are small balloons which have been hexagonally, which have hexagonal arrangement, and they've been made into a larger hexagon. And this is an alveolar unit, and these are small alveoli. Basically, these were small condoms at that time. What they were studying is the stress distribution in the central alveoli or the central balloon when the pressure surrounding that central alveolus has been changed from either 0 to 20 centimeters of water. Now here you can see, I don't know if I can reduce this. Oh yes, I can. Sorry about that. Tomorrow. So here is what the central result is. If you look at this blue circle, this is the situation, which is closed loop, not the dotted one, is the PV loop of the central balloon when the pressure surrounding that balloon is 0. What we see is for it to distend from 0 to say 200 ml, it has to go from 0 to a little bit about 20 centimeters of water, or maybe close to 25 or 27 centimeters of water. Now, when you change the pressure around that alveolus to 20 centimeters of water, and then you study the pressure volume curve of the central alveolus, then it goes from minus 60 to plus 27 to achieve the same tidal volume from 0 to 20. That is huge. So they concluded that the central unit in the condom model when the pressure around 0.20 is different, saying that the stress distribution in this lung will depend on the stress of the surrounding tissue. This forms the basis or the push towards understanding Vili. And this was soon after the ARDS was being defined or recognized. This interested several people, but none more than this paper made a huge impact on our understanding of Vili. There were two colleagues, Webb and Tierney. What they did is took rats and started ventilating them. Rats with normal lungs. These are normal adult rats who are completely healthy, have no lung injury whatsoever, or any form of disease. Here's their central result. They ventilated these rats on pressures of 14 by 0. A simple experiment, 0 end expiratory pressure, 14 of peak pressure. They ventilated them for an hour. They took the lungs out. The lungs look fantastic. There's no problem. There's no leak. The lungs have not gotten into any trouble. They had serially increased pressure. The maximum pressure they gave, keeping the end expiratory pressure 0, was 45 centimeters of water. At 45 by 0, you can see what has happened to the lung. The lung has become hepatized. Animals did not even last the whole hour. It was 20 or 25 minutes that they started dying. It was red, inflamed, thick, edematous lung, leaky with blood in it. So they said, okay, this much of pressure is what kills a rat. One of them was clever enough to add a PEEP of 10, said, okay, if this is edema, because by that time edema was being understood, and it was understood that, okay, they said it as, they called it as experimental pulmonary edema. And for pulmonary edema from cardiac or any cause, giving little bit of CPAP was able to hold patients at that time. So they said, let's keep this pressure same. They had multiple other sets of pressures, which I'm not showing, but this was their central result, which the picture they showed. They added a PEEP of 10, but they kept the peak pressure same as 45. And look at the result. The lung has changed. It came towards 14 by 0. And the animals lasted a whole hour. When they brought them out, they were a little heavier. These lungs are heavier than these lungs. There was some water in it, but they were nowhere close to dying. For hemodynamic consequences, of course, they were hypertensive, etc. But from lung injury perspective, these lungs were similar to these lungs. So now it brings to the question, is it the peak pressure? So even if with the 45 of pressure, if you had a PEEP of 10, you were able to keep the lungs going. Or is it the absence of PEEP, or what it is? They couldn't conclusively make a complete justifiable argument of why this and why not that. But they landed on something that really made everybody thinking. This was back in the ARRD, which was then the name of the Blue Journal, American Review of Respiratory Disease. And it's so, this is the paper that made the most impact, has been cited many, many times. And it actually shaped research on how the ventilator and the lung interact biologically, or what form of injury would happen from the ventilator. Almost a decade or more later, this is the model of 45 by 0 that people started working on. That, okay, there is a problem that the lung goes through when it has been mechanically ventilated, and we need to understand this more. What Webb and Turney said was that this is pulmonary edema. And back then, pulmonary edema means hydrostatic pressure, means water leak, etc., etc. Come 1985, Dreyfus and colleagues said that, well, if it was such hemorrhagic and such quick death, we don't think this may be just water. This is leak. There must be something else happening. So they went on to study the same model and showed that within 5 minutes of 45 by 0 ventilation in rats, the endothelium starts to rupture. These are endothelial blebs, very early endothelial injury. And by 20 minutes, there is nothing recognizable there. There is hyaline membrane already in 20 minutes. There is leak and there is blood and these are very good electron micrographs in 1985. So they called it late. It's not late, but in 20 minutes in the relative time frame, it's early and late. The alveolar damage happened after the endothelial injury, suggesting that this was not just pulmonary edema of water leak, but this was actually a microvascular tear, leak of protein and cells, and then damage of the alveoli, which is basically saying that you converted the lung into an ARDS lung. So this is how it changed thinking that, okay, the damage to the lungs is not pulmonary edema alone, it is actually physical trauma to the endothelium and a diffuse alveolar damage. Later, they were intrigued by this question of how did that PEEP make a difference? So if PEEP is making a difference, maybe there is something else that is happening to these lungs. And they did a very clever experiment. And this is very, very cool. This is the basis of why so before that, it now got understood that pressure destroys lung, not just in terms of pneumothorax, which of course is a gross barotrauma, or a pneumomediastinum or a pneumoperitoneum, which of course is a gross barotrauma, but even 45/0, which causes lung leak and protein and water and all of that, is barotrauma of the lung. But Dreyfus and colleagues did not sit there. They said it doesn't make sense. Even if I use the same pressure, but what if the lung does not distend? Will it then cause lung injury? So what they did is they created 3 groups of rats, one with high pressure and high volume, another with low pressure. They had applied a negative pressure, which gave them more or higher volume. And then they had a third group of rats where they gave the same pressure of 45/0, but they strapped their chest. They kind of applied a rubber band on the chest. On a rat, it's easy, which means that most of the pressure was used to push the chest wall away, and the lung actually did not distend too much with the same pressure. So they achieved low volume, high pressure, low volume, high pressure, high volume, low pressure, much higher volume by achieving, giving a negative pressure in addition to the 45/0. And then they studied leak. Now, the way they studied was different at that time, which is all right. But this is lung weight to body weight ratio and how the water was flowing and how the albumin, this thing happened. The central is that even if you gave high pressure, but you gave low volume, the leak inside the lung was significantly reduced. Wow, this is good because it means that it is not the pressure, but the volume. And even if you reduce the pressure by adding negative pressure, which would mean adding more volume because you applied negative pressure and there is positive pressure, totally the pressure reduced but the volume increased, then the leak is much higher. This went on to make them understand that it is not the pressure applied unless the pressure distends the lung, which is why they coined the term volutrauma. So it's high tidal volume and not high pressure. So they said, okay, it's not barotrauma, it is volutrauma. But together we now understand that we call it as distension-induced lung injury. Way later, on the same models, but using much more sophisticated methods, who Meyer and colleagues, very good work, went on to show that when you use this distension induced lung injury, what is this? When you use distension to injure lungs, it actually causes something like stress failure of cells. So this is cellular biology study. This was physiologic protein leak and stuff in the lungs. And when you look at cells, these cells fail in the sense there is a mechanical distension of these lungs, and then mechanical signaling which fails the cell, tears the cell, or the cells die, which is alveolar and endothelial cells. So this is called stress failure of both cells. And this is how biological injury could be recognized from mechanical stress. Trying to homogenize the two ideas, I'm just going to use a simple schematic. If this is the airway pressure that we apply to the alveolus, and then there is a pleural pressure, which is the pressure that is between the lung and the chest wall. Contributors to pleural pressure are several. Dependent would be from gravity, from the chest wall, etc. But if the pleural pressure is high, or the same airway pressure, the lung distending pressure or the transpulmonary pressure will be low. And if for the same airway pressure, if the pleural pressure is low, the transpulmonary pressure is high, which is what basically Dreyfus and colleagues did in their experiment. What they did is they kept the airway pressure same, but they changed the pleural pressure. They made it lower by negative pressure application, or they made it higher by strapping the chest. So together, volume and barotrauma are not two different terms if we apply the understanding of transpulmonary pressure, which is to say lung distending pressure. The pressure that distends the lung, or which actually produces inflation of the lung, which is the transpulmonary pressure, has a linear relation with the volume that goes in, and therefore the two together are injurious, which means together it has to be understood as distension-induced lung injury. The term volume and barotrauma are kind of a little bit historical. Now, this is what we know from volume and pressure trauma. But parallelly, a different group, there was European studies from Dreyfus and colleagues, and here in the North America, even before Dreyfus did all that, some very cool studies were being done. This is measuring pore radius, or basically leak in the alveoli, when the inflation pressure given in the alveoli is progressively increased. But this is statically increased, and you're measuring a leak in the opposite direction, which is a little bit surprising, difficult to grasp that. You're applying pressure here, the leak will be in the opposite direction. But because you're applying pressure, and because there are going to be tears and the pore radius will open up, the leak will happen on the opposite side. So that would mean that even if you give high pressure, you cannot prevent the leak after some point. And this was this relationship of static inflation of the lung and permeability. They showed permeability, and I write here moderate permeability because a few years later, another great guy, James Parker, and his entire work on Vili, showed that it's not statically inflating because that's not how we breathe. We breathe by opening and closing the lung, opening and closing the lung. And it depends on how much you open and close the lung with the peak airway pressure that the permeability will change. And they showed that it's not static inflation that affects permeability more, but it is the cyclic inflation. So if you keep opening it, there was another point around this much of pressure when the leak was minimal, but as you increase the tidal pressure, the permeability increases. So parallelly, we were understanding at that time that it is cyclic opening and closing along with this distension, which is much more permeability inducing than the static inflation. All of this is to show how we arrive and why we do things that we do at the bedside today. It just sets in well. You feel, okay, now I know it all. So the distension-induced injury, the key findings that were biologically figured out by then was that more you distend the lung, more you will inactivate the surfactant after a point in time. Where a closed lung surfactant is inactivated, keeping it open and distending it too much inactivates surfactant, which was a new thing, which is not new anymore, it is now quite known, but seldom makes it to teaching. Increases microvascular permeability, which is it causes microvascular tear, and this permeability is not only to water, but to protein and to cells, and then it causes cellular stress failure. Together, all of this will cause inflammation and eventual fibrocyte proliferation. So this is how the lung gets progressively injured. The other thing is to understand that it is the concept of trance pulmonary pressure or distending pressure, which kind of unifies the two, volume and barotrauma. The cyclic inflation is more injurious than static inflation. This together brought in the idea in 1992 when Lachman proposed lung protective ventilation as a philosophy, and then it was realized by his fellow Dr. Amato that distend lung, keep the lung open, open up the lung, keep the lung open, and use lower tidal volume, which is how it will be more protective to the lungs. So it was decades of preclinical work. And why is this important? Another key thing that one needs to remember that Vili cannot be studied in humans. It's impossible, right? You cannot subject a human to extra stress and say the lung got injured. Vili can be only studied in animals. So Vili, for those who are skeptic, believe that it is still a speculation in humans. For those who understand that biology is not too different between animals and us, there are of course differences, but eventually the trend is pretty similar. You understand, you translate one from another, you know what happens. We'll know that if a rat's lung, a pig's lung, or a dog's lung suffer with ventilation, then human lung is not going to be too different. It is going to suffer with ventilation. So Vili, well studied, documented, and can be only studied in animals. In humans, it is a speculation and it is a belief. I may say, no, we know everything about Vili. We know driving pressure. We know this and that. For sure. What we know is an association of a particular pressure or volume with mortality. And the belief is that this increase in mortality is because of the Vili. Sure. And it is a very strong belief, very strong understanding. In my opinion, it definitely happens. But for skeptic people, it might be like, oh, no, we don't know. There may be other contributors to mortality, for sure. But we also know that modulating the ventilator properly reduces that mortality, like the 6 ml per kg, reducing driving pressure, etc. which is to say that there are some ways in which we can help the survive if we do the ventilation right. So this is very important because this is the crux of why ventilation in ARDS especially is different from what we might be doing with some other patients. Now, after this decades of preclinical work, even before, we get famously told about the ARDS-NET trial of 6 into 12 ml per kg, and we believe that a randomized control trial is the way to get the truth only. I'm not sure. You can understand truth in many ways. And here is a very cool paper that Hickling and colleagues published back in 1990. What they did is they plotted their mortality of ARDS. Well, ARDS was still getting defined because we know that the American European Consensus Conference, etc., the definition that Rush and I learned as fellows were in 1994. And then 2012 was different, and now it is again different with Balik. But at that time, and severe acute adult respiratory distress syndrome was all that was sufficed. And they said that if we cause low volume or pressure limited ventilation, that is reduce the peak pressure, it was not unusual to use peak pressures of 40 at that time. If we limit the peak pressure and allow permissive hypercapnia, this is the term he coined, that is let the CO2 rise. Let's not worry too much about CO2 if the pH is okay, but let's not hit the lungs. Then the mortality will reduce. This was a retrospective study. They then did a prospective study. And this was not randomized controlled trial. This was an observational prospective study. And they showed that mortality reduced. These were the two first evidences where clinically that modulating a ventilator to give lesser support than what physiologically is demanded to achieve gas exchange actually improved mortality. This at that time was a big thing. Wow, we are all trying to ventilate patients so that we get the perfect gas, we get a normal CO2, we get an adequate PO2, and that's the purpose of the lung. But you say that you reduce it, give lesser support, and the patient will survive. This really hit into it that, okay, something wrong we do with the ventilator, and we need to reduce using aggressive ventilation and believe in something like permissive hypercapnia. This is 1994, and then 1998, we know this famous paper by Marcelo Amato, which was a single center randomized controlled trial, which had to be stopped early. This was not stopped early. This was published in two parts, but it showed that mortality reduced if we used low tidal volume. This was a randomized controlled trial. And then later in 2000, a multicentric ARDS network, 6 ml by 12 ml per kg, trying to limit the plateau at 30. And this is a study that was famously taught all the time. But we need to know, where did it come from? Why all that work has gone ahead? And therefore, those who have seen all these decades of development, they would think this was kind of not necessary, because by that time, from the impact that Hickling had shown, the end of that decade, people were already ventilating humans at 7 or 8 ml per kilo. So now we do a randomized control trial of 6 to 12 ml per kilo, which does not seem ethically correct. There are vehement criticizers of this paper, as there are supporters. A decade and a half later, yet another very strong evidence of how the pressure on the ventilator relates to mortality in acute respiratory distress syndrome. We spent, after 2000, in tidal volume control, we spent a decade multicentric studies of setting up the PEEP. Nothing worked out well. But that gave a lot of data of almost, I think, 9 randomized control trials, if I'm not forgetting. That's what Marcelo did in this paper. And he'd used something like mediation analysis. We'll not go detail into that. That's a very cool, very unique analysis that was used. But homogenizing a large population from all these randomized controlled trials, he figured out that if the driving pressure, which is plateau minus PEEP, not peak minus PEEP, it is plateau minus PEEP, the driving pressure, if it increases progressively, especially above 15, then mortality increases. The relative risk of death increases above 1 as the pressure is increased. This is yet another strong evidence of what one does with the ventilator. Now, One may say that one has done absolutely the right thing with the ventilator, and yet for survival, one had to use this much of pressure, which would indicate that the lung is very sick and the patient is likely to die, which may not mean that that pressure actually killed the patient. Potential. This is one of the ways to look at it, that this driving pressure is therefore more of an indicator than a target. There's another philosophical thing that one needs to understand, that everything that is an indicator cannot be a target in medicine, right? If lactate, high lactate, is an indicator of badness, it does not mean trying to reduce lactate by some artificial means will improve outcome. It means one needs to take care of what is giving that lactate. Same way, driving pressure has been shown as a strong indicator, but we can only say that it is a contributor to mortality if modulating driving pressure definitely improves mortality. No strong evidence for it yet, but definitely a strong belief from a lot of preclinical work. And now that we understand that driving pressure is a huge or a big component of mechanical power, it does seem and seems logical that trying to reduce it as much as possible is likely to improve the outcomes in ARDS. Here's a very cool repeat analysis that Ivan Gallagher and colleagues from Toronto did on all the studies of high tidal volume versus low tidal volume, which was not just 6 and 12 members, there were several at that time, for some of you might know. And homogenizing all that data, they found that the mortality benefit of ventilation with lower tidal volume in ARDS varies according to the elastance. Now, to be honest, this is not new. Right after the 6 and 12 ml per kg, there was papers and reanalysis which showed that if the compliance was good, which means the elastance was bad, one need not use 6 ml per kg of tidal volume. In a repeat analysis, using driving pressure is a more important target, because driving pressure can take care of elastance and can take care of tidal volume. What Ivan Gallagher and colleagues said that, rather than the tidal volume, primarily target the driving pressure. And now a randomized control trial is being done to see whether targeting driving pressure will give us that thing. We'll see. So again, building on my point here to show you these studies is that there is a definitive association that one can figure out even clinically on how we set the ventilator and the outcomes that we measure, which is largely mortality. Coming to atelectasis, can atelectasis itself, just having low lung volume, injure the lungs? This is actually one of the first evidences which came from my mentor, Dr. Kavanagh's lab back in 2003, where he showed that, again, normal lungs, which are not injured prior or do not have any infection, and if they were, ventilated on low PEEP, if they were recruited, all of them survived. If they were not recruited, that means they were left closed, then 60% of them survived, which is saying 40% of them died. And this was opposite for their leak in the BA. So Evans blue dye, or Evans blue dye that leaks into the alveoli. Evans blue is a protein-bound dye. So if it leaks somewhere, it means that protein has leaked. So in the non-recruited group was leaking protein and was dying. What is happening? It means atelectasis is itself causing inflammation and injury. It kind of makes sense that lung is not made to stay completely closed, and lung is not made to stay very high open. It's not supposed to get distended. That's why we have a chest wall. The resting form of the lung along which it works is around the FRC. So if you go below FRC and the lung stays closed, then the lung becomes sticky, the surfactant goes away, and that sticky lung will produce inflammation and leak. As was the opposite side, everything about distension, which was thought, it was also now being recognized that it is leak that was doing this. And for the first time, somebody studied the heart along with the lung, which was important because that is the second organ within the thorax. And they realized that as the lungs got injured, the right heart distended, which means this was an endovascular problem where you would also throw pulmonary hypertension and right heart dilation along with leak inside the lung. This is a very cool paper. Right around that time, Richard Albert, who's a visionary, another visionaries in ventilator-induced lung injury, wrote a very cool paper that ventilation-induced surfactant dysfunction and atelectasis could be causing ARDS, which is huge. That means the surfactant dysfunction that happens with ventilation eventually produces atelectasis, and that atelectasis will give us ARDS. So atelectotrauma, which is pure atelectasis. Atelectotrauma is also understood as opening and closing, but that probably is more related to biotrauma. Pure atelectasis can cause microvascular leak, inflammation. It facilitates cyclic opening and closing because once you stay closed and you use high pressure, you open and then you close, you open and you close, which we know from earlier studies that cyclic inflation causes lung injury. And for the first time, somebody showed that it also causes right ventricular dysfunction. We know that presence of right ventricular dysfunction or pulmonary hypertension in ARDS adds to mortality. Physiologically makes sense. Along the time when all of this was being understood, Dr. Art Slusky, Laurent Tremblay, again a group in Toronto, started thinking that if it is a mechanical component which is not producing a large leak or pneumothorax, which would immediately kill somebody, but if a mechanical component of lung or lung stress is associated with mortality, then there has to be a biological link. There has to be something that the lung is doing wrong. So they started studying, inflammatory biomarkers, which was getting relatively new at that time, in the lungs of those rats who were ventilated with high pressure, zero PEEP and high pressure, high volume. They had multiple, this thing which is controlled and medium volume, high pressure, medium value, zero pressure, high volume, zero pressure. Basically, as we increase the tidal volume, which is opened and closed with larger tidal volumes, more and more inflammatory markers, tumor necrosis factor alpha, IL-1 beta, IL-6, IL-10, several of these are now measured clinically at the bedside, which is very cool. Tell us how much of the inflammation is produced, were progressively increasing. This was the first association between how biologically measured inflammatory markers increase with increasing tidal volume. And later on in JAMA, in a randomized control trial before the ARTSNet paper, they showed that in patients who were ventilated with lower tidal volumes or protective ventilation, the inflammatory biomarkers came down and they survived better versus those who were not, where inflammatory biomarkers went on progressively increasing. This laid the foundation of biotrauma. And I recommend this paper in Journal of Medicine 2013, written by Dr. Slutsky, and a good review on Vili, where he shows that that there are several biological alterations. A lot of these have then, after that, been proven, have an association with how much the alveoli get stressed, and these biological mediators and stuff get released into the circulation. Then the circulation will carry it forward. Multiple mechanisms of these leaks and translocations. There is multi-organ dysfunction and eventually death. Because death in ARDS is eventually multiple organs failing. So a link between how Vili will cause MODS and contribute to mortality, a link comes from biotrauma, which is to say that all the distension and atelectasis, all of that produces biological trauma, and the biological trauma causes death. This is how everything got linked. Now, where at the same time, all of this being done, I'm not going to spend a lot of time on driving pressure and mechanical power. Maybe we can do that later, because those are two hot topics of the current, in our current understanding of Vili. Very recently, this paper came out, which showed that where driving pressure is important, like mechanical power and driving pressure, both are related to mortality. But a simplistic model of driving pressure and respiratory rate would also suffice. Now, in this graph, if you see the not dotted line, the straight line, which is the driving pressure, as the driving pressure is increased, the relative risk of death increases, which we showed before. Now, It is also true for the respiratory rate. So the respiratory rate, if it is increased, this is true for adults, which is here, then the relative risk of death increases. That means there is a soft point where you can use a particular respiratory rate and a lower driving pressure where the mortality will be less. The relative risk of dying will be less than 1. Mathematical computing is hard, but philosophical concept is important. And then applying that concept at the bedside with modulations that you can do will give you the best result. There are two examples, one with very poor compliance along 14 ml per centimeter of water, with sometimes normal compliance for children, but in adults this is bad. You know, the odds ratio of death overall in this patient are higher because the patient is terrible. But they will increase as the driving pressure is high and the respiratory rate is also high. But if you reduce the driving pressure and increase the respiratory rate to only a particular limit that is allowable, then this odds ratio can be brought down. Not a huge reduction numerically, but every chance you want to give the patient, this is a likely thing to do. Contrast that with this, where you have a slightly better or good compliance, which is to say a good last chance as well. The odds ratio of dying is lower when you have a driving pressure of 12 and respiratory rate of 25. But if you try to say, oh, let me achieve a little bit better driving pressure, come to 9, and for that matter, let me increase the respiratory rate, then that respiratory rate for this compliance of the lung is actually higher and may increase your odds of dying. So this is how the two can play a role. Again, another evidence of what you do with the ventilator can impact outcome. All right, these are clinical studies that have put in with all the biological studies that have been done. So overall, this brings to the concept of lung protective ventilation, where you open up the lung, keep the lung open, use low tidal volumes, maybe not, use low driving pressures as much optimally proper, understand the respiratory rate better, and the question of optimal PEEP. Exactly how to set it up, nobody knows it well. Some more studies to come, but that is an entirely separate topic that we can discuss some other point. But try to use optimal PEEP. Now, all of this was, hypothesis that was, well, let us first ask, how are we doing with time? Is everybody okay?
Yes, Bhushan.
Hello?
Go. Yeah.
Okay, great. So this was all about how the alveoli get injured, how leak happens, how the forces on the alveolar side have been studied. We proposed in 2 of our papers recently published that a competing hypothesis for Vili, where studies on the air spaces are being done, but there could be vascular forces which are also contributing. This is electron micrograph from one of my rats. And these are the 2 papers that I'm talking about, both in the Blue Journal, and I did it with my mentor, Dr. Kevin. I'll just briefly touch upon these. These are still conceptual, but bringing you to light that it is still an ongoing research endeavor of studying how ventilator and the lung interact. It's very, very fascinating. In what we did in this paper, which is the first one, I went back to the 1974 Webb and Tierney. Remember, I showed you those lungs, 3 rat lungs, 14 by 0, 45 by 10, and 45 by 0. The most interesting 2 groups in that was 45 by 10 and 45 by 0. We repeated the entire experiment of Webb and Tierney and showed that, okay, those results are still present. That means we can properly replicate those results. And here we instead of studying the ventilator pressures and stuff, we decided to study vascular pressures. Because in my mind, if somebody died in 20 minutes, that is too fast a pulmonary death. And when I was observing these rats 45 by 0, they were not dying because of hypoxemia. Their PO2 was still okay till that 20 minutes, but they would suddenly die with a florid pink edema through the ventilator tubing. To me, this seems more of a cardiovascular collapse than an hypoxic death, which is what you expect with ARDS. So there is something definitely wrong on the hemodynamic side. And probably that is also contributing to this lung injury. Why don't we look at it? Why don't we study it? So we did echoes in rats. It is possible. And this is the group of 45 by 10. And with inspiration, we expect that the pulmonary blood flow will lower. With expiration, the pulmonary blood flow comes back, goes up, goes back. This is expected. Very high tidal volumes, right? But 45 by 0, even higher tidal volumes. What is surprising? That at the end of inspiration, there is no pulmonary blood flow whatsoever. That means the entire lung is in zone 1 condition. There is no blood flow. So when you do high tidal volume, you can reduce the blood flow to certain segments of the lungs completely, totally hyperperfused or no blood flow. And because the entire cardiac output then has to go through the expiratory cycle, you can see that they're much more peaked and much more cardiac output that goes to the lung when the lung is kind of collapsed near zero. When the lung is collapsing, you have a lot of blood flow that goes in. When the lung is inflated, there is no blood flow going in. That means the two forces are now are asynchronized. In a spontaneously breathing individual, when you breathe negatively, air goes in the lung and blood goes in the lung, right? But this becomes out of phase in positive pressure ventilation. And it certainly goes out of phase in here too, but here it goes too much. There is just no blood flow. One of the proposition was that, okay, maybe the capillaries are getting completely compressed and this huge afterload that is being done. But no, look at this video. You see the LV and RV quite well. Both relations are good. RV-LV ratio is fantastic. In here, the RV is completely smooshed, which means that with lung inflation, more than the afterload is actually the preload on the right side, which goes lower. Because there is no preload, there is no forward flow into the lung. And we said this high tidal volume ventilation actually causes flow, no flow, or high flow, low flow condition inside the pulmonary vasculature, and that causes vascular shearing. Where we know about alveolar shearing, alveoli open and close, the vessels that open and close, microvasculature, that will bring endothelium rub against each other and injure. And we know from previous work that the endothelial injury precedes alveolar injury. So maybe these forces are much more stronger, and we should be targeting or measuring echo or looking at cardiovascular measures while ventilating patients. There's already a group in France who says that you should recruit not looking at the lung, but looking at the heart, which makes sense. And the second group is set of experiments that we did again in rats is what we call is lung deflation injury. And then some other day I'll talk to you about that on pigs as well, which we just concluded. But in rats, these are again normal rats. We were studying some different experiments, and at a very high pressure from 12, which is not high for humans, but 12 is high for rat. When you suddenly remove that pressure to 0 in a normal rat, lungs are completely fine to start with. Then they started dying. You can see there is hemorrhagic edema and death. I'm like, what did just happen? These were normal rats. We were just ventilating for that kind of experiment, and you reduce the PEEP and they died. And then sequentially, with a lot of work, we showed that, on a PEEP, which is 11 or 12 centimeters of water, just before deflation, you see a good alveoli intact, little bit of edema, some swelling of the endothelium. But within 5 minutes of deflating the lung, like collapsing the lung from high pressure to low, you see that the endothelium is toned, the endothelium is rounded. This is electron micrograph at very high magnification, as you can see, 5 micrometers here. There is interendothelial leak. Neutrophils have started coming in, and the alveoli have become edematous. There are RBCs in the alveolar sac. That means there is leak, there is water, and you see this intraalveolar septum, which is so edematous and boggy. So it was not inflating the lung that was injuring, but suddenly deflating after inflation was injuring. We said this is deflation injury. That means deflating the lung. How many times that happens at the bedside? You disconnect for a suction, disconnect for a transport, whoop, the lung would go close. And this gets us worried that maybe even that is a bad maneuver and probably injuring the lung. So we left it there. More work to happen on that to show that that actually is clinically relevant. But just to give you a flavor of where the field is moving. Lastly, I wanted to talk about Psili, or what physiologically better be called as effort-induced lung injury. Are we still good with time?
Yeah, absolutely, Bhushan. Go ahead, please.
All right. Why was this important and interesting? Through a lot of clinical observations and belief, people thought that should we be paralyzing patients or not? And it was important to know whether early paralysis was helpful at all or not, because patients would breathe hard and there was a worry that that may not be very good. There was a landmark paper in New England Journal of Medicine 2010 by Papazian and colleagues, which showed that early paralysis, this is in adults, giving a cisatracurium infusion versus not, survived the patients. Probability of survival was better. So why is it that paralyzing patients survive the patients or reduce mortality? Here is a schematic that came out that was shown in 2002, and a slide that is very carefully drafted by my mentor, Dr. Kavanagh. We all breathe with the diaphragm effort, which is not equal. Our diaphragm does not move like a piston pump. There is a strong, the crural diaphragm or the muscular diaphragm, which is in the back, which is solidly supported by the back, works harder. It pushes the diaphragm harder. And the fanned out tendon, which then sits around the lower part of the thorax, moves less. As a result, more ventilation or more air goes in the back, in the dorsal areas of the lung, and less goes in the front, which makes sense because that is where most perfusion is. And therefore, it causes a perfect VQ match in both parts of the lung, good here and good here. And that is how we are set to breathe. That is how evolution happened. Now, coming back to this concept of trance pulmonary pressure that we discussed earlier. That is the pressure inside the alveoli minus pressure outside the alveoli is the lung distending pressure. Let's consider a theoretical possibility or a schematic possibility here. A patient is breathing spontaneously, generates a negative 20 of diaphragmatic pressure or pleural pressure. The atmospheric pressure is 0, so the transpulmonary pressure is 20, 0 minus of minus 20. And that is the lung distending pressure. Lung distends with that pressure. All good? Now let's say we intubated this patient and the patient has been paralyzed. No spontaneous breathing, mechanically ventilating, peak airway pressure 30. At that peak airway pressure, the pleural pressure can go to positive 10 because now you're paralyzed, the chest wall falls in, the abdominal contents fall in, the lung weight produces the pressure. Transpulmonary pressure, still 20, all good. In both the situation, the lung distending pressure is the same. So the lung distends probably to a similar amount. Regionally, it may do different things. But overall, the lung distending pressure is same. Now the patient is waking up and you allow spontaneous breathing on a pressure control mode. But the patient's drive is still high. You're giving 30, the patient starts taking minus 20. What will happen to the transpulmonary pressure? 30 minus of minus 20, 50, which is huge. So where this was probably protecting the lung, this has become more than double. And this distending pressure, transpulmonary pressure, as we know from previous studies, is lung injurious. This is how a global model of spontaneous effort would work. There is evidence towards effort or P-Psili even before the modern concept. And in this paper in 1999, Khaled et al. Showed that in a volume preset ventilation, the total volume is fixed, which is the flow is fixed. If there is significant negative pressure breathing, then the airway pressure will drop without the volume being added. If the volume goes in with the negative pressure, that is fantastic, then it just distends. But because the tidal volume does not go in, that means the lung distension doesn't happen, but the pressure goes in, then it produces negative pressure edema. They call it as negative pressure edema. Basically, this is effort-induced lung injury. What will happen in pressure preset ventilation? This is pressure preset. There can be something like double triggering. What is double triggering? That the I time with which the patient breathes is longer than the I time that the ventilator gives. A separate topic someday we'll discuss, but the concept of neural I time and mechanical I time. And we don't try to match it always because we don't know what patient's neurolite time is. But if the patient wants to breathe longer, then the ventilator gets double triggered in the same patient breath. But that would give 2 tidal volumes, which stack up to become a larger tidal volume in that breath. And imagine if this happens once in 3 or 4 breaths. That means every third or fourth breath, the patient is actually breathing 12 ml per kilo instead of 6 ml per kilo, which we know is injurious. So asynchrony, which gets produced from spontaneous breathing, can potentially contribute to high tidal volume or contribute to distension-induced lung injury. Now, these are very cool papers that my colleague Takeshi Yoshida produced, some from Japan, some from Brazil, and then some from Toronto. He showed that, spontaneous breathing during lung protective ventilation in an animal model can be helpful or can worsen injury, and it's associated with high transpulmonary pressure. So if there is positive pressure ventilation, mechanical ventilation, with a spontaneous effort which is weak, which means there is not high transpulmonary pressure as we showed earlier, then the lung is not that bad. But if the effort is strong, that means the transpulmonary pressure is higher, then that lung gets sheared, because you can imagine that opening and closing the lung is getting sheared, and this causes injuries. More effort, more injury. So it's not that all effort is bad. It is high effort which produces high transpulmonary pressure, which is bad. What is that value of high transpulmonary pressure above which we should not go or below which we should play? Still a flux, we don't know. But I would say if you have a negative pressure of more than 10, then you need to worry. And it's not just negative pressure, it's also the time spent on that negative pressure, which comes to pressure time product. A separate discussion, but today it suffices to say that it depends on how high the transpulmonary pressure is. Second, it depends on what form of lung injury was already present. So if you're a mild lung injury, which is like a mild ARDS, and you do not allow any effort, then at the end of the experiment, the lungs are inflamed. But you allow spontaneous effort with the same amount of injury, then the lungs become better, the lungs improve. Contrast that with severe injury. That means lungs have been severely inflamed, there is severe ARDS, and you don't allow the effort, the lungs are good. If you allow effort on top of severe injury, which means the lungs are already bad and now there is heavy effort happening on that, then those lungs get damaged more. So mild injury, effort helps. Mild ARDS, do not paralyze. Severe injury, effort harms. Severe ARDS, probably early paralysis is better, and that's what Papazian showed. So this is after Papazian's work that Takeshi Yoshida showed this as possible explanation. Here's a very cool, another thing that he showed. Here is actual data is online in this paper. A 40-year-old male who's ventilated on pressure control ventilation, there is no effort. You can see that the tidal volume goes in. By the way, this is electrical impedance tomography. It's a very cool device where you can see ventilation, how it happens regionally inside the lungs. And here, the effort is allowed to be preserved. Look at the difference. When the effort starts, all the ventilation goes in the lower area, then the ventilation goes in the upper area, and then there's expiration. And starts here, goes here, and expiration. Which is to say that even if you've set it as 6 ml per kilo, majority of tidal volume initially goes to half of the lung, which would mean that per tissue of lung, the tidal volume is actually doubled. And then it goes to the rest half of the lung. This, they call it as penduloft. And therefore, even if you are protective on the ventilator, in the regions of the lung get more distended and some regions get less distended, adding to injury. Here's a schema that Dr. Cavan have made, and it's a very cool one. Here is the endotracheal tube. Here is an alveoli, here is an alveoli, and these are pleural pressure. These are strong swings that are happening in the back where the diaphragm is. Patient is supine, and there are weak swings that happen in the upper portion. Where the swing is more, that is where the lung air will go. So all the air first goes to the lower part of the lung. That is what distends that lung. Not only so much, it probably so strong that it may also pull air from the upper part of the lung, which is not getting air only from the ventilator. It also gets air from the ventral portions of the lung. And this is what is pendulous, which means that regionally we still might over distend the lung and open and close the dorsal parts of the lung, adding to injury. Conceptually homogenizing all that work, these three stalwarts, Dr. Brashad, Slutsky, and Pesenti, were leaders in this field, wrote up this paper saying that that initial lung injury may be because of a virus, a bacteria, or trauma, aspiration, whatever, has to lead to a capillary leak. That will lead to a little bit of edema or more edema. That will cause impaired gas exchange. That will increase the respiratory drive. And that increased respiratory drive will make patient do a lot of work, will cause negative pressure or pulmonary edema, will increase tidal volume, will cause pendulifts, will cause increased esophageal pressure swings, and all of these mechanisms that we went through, and will add to that injury. And this is how it will propagate and propagate and propagate, what they call a spatial self-inflicted lung injury. So then what do we do? We should not allow anybody to breathe, paralyze the diaphragm? No, but we need to exercise the diaphragm. So what we need to do is make sure at the bedside we are better synchronized. We have reduced the effort by non-paralyzing means, and if required, paralyze, that is to sedate, recruit open the lung better so gas exchange is better, reduce acidosis, and use PEEP and prone position as suited. This is how we can prevent the effort-induced lung injury, or if needed, paralyze. In summary, what we've seen today really contributes to high mortality. Driving pressure and respiratory rate are the newer modulations that we can do at the bedside. Vascular contributions are being recognized, so look at the heart as well. And Psili, it is the balance of the lung and the diaphragm. All right, thank you.
Thank you so much, Bhushan. Wonderful talk, as usual. Any questions from our fellows? All right, so meanwhile, yeah, Deepak, yeah, go ahead, please.
Sir, no, sir, I don't. It was a very.
So, Bhushan,
yeah, if fellows don't ask question, it tells me that my talk was not good.
Sir, actually, I have a doubt. Means I don't know whether it's correctly. The thing is, like what you said was like, if the pressures are not dangerous, whatever tidal volumes we are getting with the same pressures, it is more harmful to the lungs. Is it so? Like,
Yeah. So what is important is whatever pressure you give or whatever tidal volume you give, how much of lung distension are you achieving? For instance, if the lung has a very low elastance or very good compliance, then using higher tidal volume will make that injurious. But if the lung has very high elastance, or to say very poor compliance, then even 6 ml per kg may be injurious. So what you set on the ventilator, but what the lung sees is more important, and that has to take into consideration of how bad or how good the lung is already. Does that make sense?
Yes, I think what I particularly like, Bhushan, is calling this term as a distension injury rather than distension-induced trauma, because earlier it appeared like pressure and volume are two different entities. But moment the pressure was made transpulmonary pressure, then they are equivalent, whether you talk in terms of transpulmonary pressure or in terms of volume, because the earlier study of barotrauma did not actually take the transpulmonary pressure into account, and they just spoke about plateau pressure. But
yes,
at the end of the day, there has to be a distension. So the distension is linked to either transpulmonary pressure or the volume, right? So I think that that term is probably much more better than sticking to volume or probably saying pressure trauma. What you said in terms is very relevant, because the initial setting of tidal volume was essentially based on ideal body weight, and now I think it's quite clear, because you need to set the tidal volume to the available ventilatable lung, not based on your body weight. So there the compliance equation really helps, because if you're very poorly compliant, it tells you that the amount of ventilatable lung is much more smaller, so you need to have much smaller tidal volumes.
Exactly.
And yeah, and then so those are good points. And I think the point you made also about driving pressure, I think was very important. Whether it's an association or indicator of severity, or whether itself is a indicator for mortality. And I thought there was one point which, when I was going through driving pressure, how you achieve the driving pressure also is very important, because when the study came, there are some studies which try to decrease driving pressure as a target by increasing PEEP. So in the sense that, so you have, let's imagine 30 of plateau pressure, and say you're on 10 of PEEP. Now, just purely because you're showing driving pressure is associated with poor mortality, people have increased PEEP to 20 and made driving pressure less than 15, make it 10. Now, those studies clearly showed that moment you increase PEEP to that extent, it causes very significant static strain, purely because of static distension, which happens because of that PEEP, and that was associated with high mortality. So the idea behind this achieving good driving pressure should be at the cost of achieving best compliance. So if you achieve this driving pressure by optimizing your PEEP, for example, if you reached a PEEP of the same 30 by 10, if it reaches 26 by 2 or 24 by 12, and then the driving pressure actually becomes less because you found that 12 is the best PEEP in terms of compliance, then that, when it's associated with the best compliance and a driving pressure which is associated with dropping plateau pressure, then increasing PEEP, those are the ones which seem like associated with better outcome than intentionally trying to manipulate your PEEP, getting up very high, trying to narrow the driving pressure. So, how we reach the driving pressure also matters a lot than just aiming at the driving pressure. Okay? Yeah.
Yeah, I completely agree. It's an entirely separate discussion on how to modulate driving pressure, because there are two key factors. One is, are you able to open the lung? That means, should we be recruiting them to the best compliance, which would automatically mean that the driving pressure will come down?
Exactly.
Or we should just reduce the tidal volume.
Exactly. It sounds like more of a surrogate marker about how well have you recruited the lung rather than anything else.
Yes. So now, for example, the trial that you're mentioning, the alveolar recruitment trial, where they try to use very high PEEP to lower the driving pressure, actually increase mortality.
Exactly. Yeah.
Yes. So, and they achieved the driving pressure quite well. They came to 11.
Yeah.
But if you again, the concepts are, did you over distend the non-distendable lung? And that's what happened. So to believe that a particular number on the ventilator is all that matters without physiologically thinking of what that number is actually doing to this patient's lung will dissociate us. And that's why the problem with clinical studies or randomized control trials, which cannot address lung biology or physiology. For instance, if a lung was not recruitable, there was no reason to open that lung with a high pressure and then come down, etc., etc. So I agree with you. The way you modulate these values at the bedside will depend a lot on how the lung actually is. Is the lung recruitable or not recruitable? Is overall compliance too good or too bad? Do I have available lung volume to ventilate enough? If not, should I use something completely different like prone or even ECMO and not, cause more injury to the lung?
Yeah. Just one more question, Bhushan. This is about regarding mechanical power. So whatever I could understand and read through mechanical power, people are looking at this single digit number, whether it's 12 joules or 14 or 15. And the problem with this is it's only one aspect of the whole game, because you're not looking at to what extent and the regional distribution of power. You're just talking about one dimension, that's the power applied to the lung, but you're not looking at the compliance of the lung. For example, if it's a poorly compliant lung, a very small portion of that lung is exposed to 12 joules, for example, versus a completely compliant lung, which everything is open and the whole power gets redistributed to the entire lung. And also in inhomogeneous lung, again, there's a redistribution which is not homogeneous across the lung. So I'm not sure if studies are really looking into these aspects also, because people are coming up with numbers, people are coming up with studies, really with not complete understanding about how it actually impacts.
This is agreeable, totally. That mechanical power is also an indicator of badness rather than a target of modulation.
Exactly. Yeah.
And if it has to be a target of modulation, it has to be done well. It has to be understood of changing what aspect of the mechanical power will give me the best benefit for a given patient. For example, PEEP, driving pressure, respiratory rate are all components of mechanical power. In some patients, modulating PEEP might give me benefit, in others reducing driving pressure, in others respiratory rate, and so on and so forth. So it's a lump which probably, at least from my understanding and listening to Dr. Gattinoni directly, was to come on a ventilator, and I don't know if it has made it, I think it's still distant, to show that, okay, there's something that is wrong, which you need to address. I don't think the proposition was, and which, but unfortunately will become, is because once you give something a number, you want to bring that number down. And whether you do it right way or wrong way, that becomes secondary.
Yeah.
So say if you are showing a joules of 25 and you're like, something is terribly wrong that I'm doing. I need to just reduce this number to 12. So I do something to the ventilator, which will bring that number down, but might not do something good to the lungs. And this is a disconnect between how a mechanistic study does not come to bedside, or what Dr. Gattinoni has been trying to say is that it's an energy transfer, and it's how the mechanical is basically applying physics to physiology. It is trying to translate stress and strain into a homogenized idea of mechanical power. But that's much more mechanistic, much more basic science than a target for a bedside clinician.
Yeah.
Than something that the bedside clinician should just start playing with.
Yeah, exactly. And I think one of the important contribution, according to me, of power is a realization that apart from your P-plat and possibly PEEP, there are other parameters also which can contribute to lung injury, like high respiratory rate, high inspiratory time, and also this contribution of driving pressure into that equation. So many of us don't think too much about respiratory rate. We don't think too much about inspiratory time. So it's not just the how much pressure, but how it is delivered in terms of the time specifics. How long in the respiratory cycle the pressure is exposed. That aspect comes into this mechanical power equation, which I think can help us to know, okay, optimize other aspects which we don't seem to focus very often.
Exactly. Yeah. One needs to look at it entirely, break it down, and for that given patient, whatever the best thing that you can achieve is achieved. Agreed.
Thanks a lot, Bhushan. Any questions from any of our fellows here?
I have a question. Yeah. Like you told that even high respiratory rates also like more dangerous. So suppose sometimes we'll be struggling to ventilate the child even with proper all the settings and all suctioning. Sometimes driving pressure also will be around 15, but still the CO2s will be very high. So at that time we will be increasing the respiratory rate even in the ARDS children also. So how to know that we are not giving appropriate respiratory rate, like we are causing more damage to the lungs?
Yeah. So here this is a very good example of actually doing a power calculation. What you want to do with driving pressure and respiratory rate is try to see if your calculated power has not changed too much. If the driving pressure is constant and you increase the respiratory rate, which changes your power calculation higher, if you can build it in and stuff, some people have a software and some people have done it, then it is the same strain. So it's basically I give too much strain for some less time. I give lesser strain for more times, but if I reduce the strain and still give it many times, it would still be injurious. Exactly what that value is a very difficult thing to know from bigger trials. Nobody knows exactly what that number is, and it's going to be different from population to population. But in a power calculation, if your number hasn't changed too much, if you were from 12 to 15 and you've just gone to 16, maybe you're okay. But increasing your respiratory rate, if it increased your power to 20, then you know that you've done something wrong. It doesn't tell you how low should you come. It's not very linear. But again, you need to come down to some value where again your power calculation hasn't moved. That is about the application of power.
Any particular things apart from this power calculation?
The other thing which physiologically makes sense at that time when you are struggling with ventilation, not as much with oxygenation in an ARDS, is to use HFO. Now, here is something controversial that I'll say, but majority of the times people want to use HFO as a recruiter device, and it's not a very good recruiter. Recruitment of airway pressure is the same. If the conventional ventilator could not recruit, the HFO will do a very similar thing, but it is actually a phenomenal ventilator, as in CO2 removal device. So without increasing much of airway pressure on the HFO, which is giving the same airway pressure, which will keep the lung distended, use it more as a ventilator because it does a very different physiology of ventilation. It's not a bulk flow ventilator, as we all know. I know, I'm sure you know HFO physiology, but that is a very cool way to get more CO2 out. And depending on how much, now the power calculation is difficult to do on a HFO, but it can be profoundly high. If little bit of increase in our delta pre with a very high frequency, it could be very high, or because the delta P is so low that your power calculation can be very, very low. So the U-shaped curve for that, I think, and that is something that we should work out mathematically, will be very different from conventional ventilator. But from a ventilation perspective, HFO is a good device.
Yeah, and just to add to what you've said, adult studies showed that HFOV actually increases mortality. And one of the things they said was, is this power calculation, saying that probably because the rate is so high, it's possible that the power actually delivered is much, much more higher, and that could be a reason for mortality. A speculation, but nonetheless, I mean, where this power equation is used to explain these kind of aspects. And like I exactly said, and I think just being mindful about these settings is important, and things like trying prone ventilation, for example, and trying to homogenizing, those things can be considered as a strategy when you're struggling with the carbon dioxide removal.
Yeah, prone also will improve gas exchange and can actually improve CO2 clearance. And then of course you do things which reduces CO2 production, deeper sedation, reduce your carbohydrate load, food, etc., and see if those things help.
Thank you.
Any other questions? Yeah. So thanks a lot, Bhushan. It's really amazing that you're taking almost an hour and a half and spending time with us.